Hello, everyone, and welcome to CCA's Medical Minute podcast, sponsored by Kroger Health. I'm Sherry Hughes. We are continuing our ASCO Direct, a patient perspective series, and today we're going to be talking about some cancers and some abstracts that pertain to cancers of the reproductive system. Joining me this day is our beautiful oncology nurse practitioner, Jill Hunt. How are you, Jill?
Good, thank you.
And also Dr. Tom Herzog, Deputy Director of the University of Cincinnati Cancer Center. He specializes in gynecologic oncology, obstetrics, and gynecology, and he's also the president of the Gynecologic Oncology Group, otherwise known as the GOG Foundation. Hello, Dr. Herzog.
It's great to be here with you. I'm looking forward to our discussion. Thank you for having me.
Thank you very much for being here. Now, we're talking about some of the things that took place in ASCO, and there were just so many because 5,500 abstracts. But today we're going to try to drill down into a couple of them, and largely dealing with cancers of the cervix, the endometrial, as well as ovarian, things like that. Let's talk about, Dr. Herzog, maybe a couple of the most interesting abstracts that came out of ASCO this year.
Yes, I guess I'm an optimist, and I'm a realist and an optimist. So all my years of doing this and going to that very meeting, as well as many other meetings, you see a lot of content that comes out, much of which doesn't come to fruition. Yeah. So when I was asked to talk about ASCO, probably about 20, 30 abstracts, which are papers that are being presented that may or may not even be in print yet, so we always wait for the final manuscript and the final study analysis to make our final determination. But they're a real good representation of what went on in a clinical trial. And so I had all these swirling abstracts in my head, and when you said, well, look, it's called the Medical Minute, I was like, well, that probably won't work too well. Fortunately, it's not just 1 minute, or we might not even get the title out on some of these. Mm-hmm. But I brought it down to 2 abstracts, and the reason I did that is that they do encompass multiple cancers, specifically one of the abstracts that we'll talk about second. And then the first one, I think, is a real breakthrough in platinum-resistant ovarian cancer. And so platinum, when we think about ovarian cancer, you have upfront diagnosis, and unfortunately, almost 3/4 of women present at advanced stage disease, meaning the disease is outside of the pelvis and the abdomen at the time of diagnosis. And so with frontline treatment, our goal is to obviously get started on systemic therapy, but also surgery is a big part of that. And either up front before we do any chemotherapy or after several cycles of chemotherapy, we try to remove as much tumor as we can. And our goal is to get the tumor down to no disease that we can see. We call that no gross residual, or nothing we can see by the eyeball. Undoubtedly, when there's tumor that's spread throughout the abdomen and pelvis and even into the pleura of the lungs and so forth, we know that despite our best debulking efforts, that there's still billions of cells remaining that you can't see. They're subclinical. We can't even see them on imaging after the surgery, which is wonderful. However, we know they're still there. So therefore, we have to give therapy that goes everywhere in the body to try to fight that. We've had real breakthroughs in ovarian cancer in that we've had over 10 approvals in the last 7 years in this area by the Food and Drug Administration, so FDA approval, so available to patients. And many of these have revolved around what are known as the PARP inhibitors up front, and they've made a huge change in the outcomes for our patients with ovarian cancer, especially those with a BRCA mutation or what we call homologous recombination deficiency, which is where there's problems with DNA repair, and the PARPs are particularly great at leveraging that defect as a therapeutic option for women with these diseases. So it's exciting that we've had so many breakthroughs in frontline. Then, unfortunately, of those patients who present with stage 3 or 4 disease or advanced disease, of which I said it's almost 3/4 of the patients, a large percentage, 70 to 80% of those, will recur at some point. And because of that large number of recurrences, we need options for those patients in the platinum-sensitive setting or the platinum-resistant setting. And we arbitrarily define this based on a timeline of when's the last time you've had a platinum compound, a type of chemotherapy. So you may know it as cisplatin or carboplatin. There's also oxaliplatin. But we usually use carboplatin. And if it's been more than 6 months and the recurrence is then documented by imaging, tumor marker, what have you, or physical exam, we then consider that patient to be platinum sensitive, in which case we usually incorporate platinum doublet and then maybe some other maintenance therapy, bevacizumab, for example, or other drugs with that. If they're platinum resistant, that presents a problem because we have less options. But we have more options than we've ever had, which is the great thing. It's really encouraging. And so what I'm most excited about, getting back to your question, is that ASCO this year, we had a abstract that showed an overall survival advantage with a whole new platform of compounds. And I'll explain, what that is. But that's what, to me, was the most exciting, is that we've actually shown a statistical difference in outcomes for overall survival in platinum-resistant disease, which we heretofore have never been able to do. So it's exciting for our patients.
And Jill, you were saying that there were maybe a couple of cases, different trials that really kind of stood out, kind of like in relation to what Dr. Herzog was saying. And one is that Destiny pan-tumor.
Nope, I think he was referring to the Mirasol.
The Mirasol.
Yeah.
Okay, that's one of them.
Yes.
Right.
So
but there's the other.
There is the other. The other would be the Destiny pan-tumor 02. But to piggyback a little bit on what Dr. Herzog was saying, because he did break it down really well, but sometimes docs are a little doctory.
Technical.
And so sometimes like patients need to understand that, when cancer is being treated, we have the first line of treatment, and kind of like what he was talking about, using those platinum-based drugs like the carboplatin and cisplatin. And, we have a certain response that we expect to see when patients get treated with that. And we would love if everybody could be cured with that frontline treatment and surgery, but unfortunately that's not the case. And ovarian does tend to be one of the ones that is a little bit more persistent. And so having options in a second line setting, because previously, like when you start looking at second line settings and a lot of the different treatment types for all of the different types of cancer, you get a significant decrease in how many patients respond or how much of a response you get. And so when you're looking at, we're now in our second line treatment and we might get a 15-20% response rate, and sometimes it's not even that great in some of the tumor types. Having a treatment that has proven in a second line setting to have such a great response is a huge deal for those patients.
So I'm going to be the patient right now because, I have once been a cancer patient.
Yes.
So if someone at home is listening to us right now, Dr. Herzog, and they want to know, I hear all this and I hear some excitement, but what does it really mean for me, the patient at home that is perhaps going through ovarian cancer at this very moment, or a relative or a friend?
Yeah. Well, let me go over a little bit of the data, if I could, from that, and then broaden that, because that's a really important question. And Jill, you bring up a great point. The beauty of ovarian cancer is that despite its persistence, which is absolutely a good characterization of the disease in terms of its natural history, it is generally chemo responsive for quite a while. And so I have a lot of patients that are alive for over a decade. With advanced stage disease, because the first line response rates are really 80+% to where we have good responses, and now with some of the maintenance and so forth, better. And then in terms of cure, some of those patients are cured with just the front line. So we've said a high rate of recurrence up to 80%. It's probably a little lower than that, but say 20-25% are cured with just that, even with disease widespread.
Yeah.
So that's important to stress. Getting back to the Mirasol, what I guess I'm so excited about is that this is ushering in a new era in the use of what we call antibody drug conjugates. So ADC is the abbreviation. And what is it? It's an antibody. So it's a antibody, which is something that's a protein that binds a specific target. And the beauty of that is that you can make these drugs more specific for treatment in that they don't hit the normal cells in your body, thereby avoiding some of the toxicity. And it's not to say they don't have any toxicity, and we can get into that if you'd like. But what's great about it is that there's much more specific targeting of the tumor, which is really exciting. The drug, well, that's really the payload or the warhead, if you think about it as a missile. So you're sending out this complex that's going to go to a specific spot. So you have your sensor for targeting, that's your antibody. Then you have the drug, which is the warhead, the payload that you're going to deliver to the cancer, try to kill the cancer, right? And then you have this conjugate, and conjugate just puts the two together. It sounds like
makes it more powerful, right?
Well, what's important about it is you can do things scientifically with the conjugate to change how much of it gets into the tumor, how much of it seeps out to some surrounding tissues to kill other tumor cells, but that bystander effect. But it also affects toxicity, right? Because now you may be starting to hit some of those normal cells, but it sort of broadens if you think of a bomb, it broadens that zone that your kill zone, if you will, not to be so war-oriented here, but we are going after those cancer cells, right?
Well,
that's what we're trying to do.
And cancer patients are at war with their cancer.
Exactly.
So,
definitely.
Yeah, exactly. And
now, is this treatment appropriate for every second-line platinum resistant?
No. So as I said, so you get into that platinum resistant group and you have less options than what we've had. So this is a new option for that. One of the things that the target on this is a protein that's expressed on the cancer cells known as folate alpha, folate receptor alpha. So you're going after that receptor that binds this compound to the cancer cell. It then takes that conjugate knows to then drop off the bomb, if you will, and the cells automatically, cancer cells bring that into the cell. In this case, the payload, if you will, is an antitubulin, which is almost like a taxane.
Which is a type of chemo.
Yeah, it's myotansoid DM4. But the point is that the taxanes are really important. If you've ever been to New York, you see all the scaffolding going up and down. That has to happen to keep cells functional. And what it does is it disrupts the ability to tear down and put up scaffolding. And so eventually it results in cell death because it just gums all the functions up.
Right?
Yep.
Yeah.
It just messes everything up in the cancer cell. And so that's how this works. So it's probably, and we found through other studies that the drug works best in those that express that receptor at a high level, because almost 90% of ovarian cancer cells have that target on it. But it's probably about 30% or 35%, somewhere in there, that overexpress it to a high level, 2+ on testing.
So breaking that down,
Yep.
if we have patients who have had a recurrence, they've done frontline treatment, they've progressed through that, and now they're resistant to cisplatin, and they're looking at their treatment options.
Right.
Now, platinum base is no longer an option, and so for those patients, about 35% of those patients will be high expressors of this protein.
That's right.
Where this treatment would be beneficial for them.
That's right.
So are we talking about pill form treatments or intravenous type treatments
Yeah,
here?
good question. This is given intravenously.
And what's the side effects look like?
Well, side effects, there's some class effects of these, obviously fatigue, things like that. But you can have some eye changes, some keratopathy, dry eyes, that type of thing. So there are some eye drops and so on that come along with this. We don't use contacts. We discourage contact use during the treatment. So there are some inconveniences for sure.
Well, but they're just that, inconveniences. We're in the war. Remember, Jill, we're in the war. We're fighting.
What about the other things like the nausea, vomiting, hair loss?
Yep. Yeah, you can have neuropathy as well. You can have some nausea, vomiting. Hair loss is, I think, pretty minimal, but can occur.
Can occur.
Yep.
Okay. All right.
Well, this
And just to say that we gained about 4 months in overall survival,
Which
is wonderful.
Which is great. And remember, there's lots of other drugs and compounds and that we can give, so all those things become additive. Progression-free survival also increased in the study. And I think the biggest thing that we as physicians are excited about, and patients and their families, when you come into the office, what do you want to hear when you're getting chemo? You want to hear that you're responding.
Yeah,
So the response rate was 42% in the mirvetuximab arm, up against, it was randomized phase 3 study, up against 16% in the group that received traditional chemo, either weekly paclitaxel, pegylated liposomal doxorubicin, or topotecan, which are common agents we use in platinum-resistant disease. So pretty exciting.
That's a big difference.
And as we're wrapping this up, from the patient perspective, they're walking into an office. Do you tell them, give them this information that there's something new from the U.S. FDA approved for them, or how do they have access to knowing that these medicines now exist that could help them?
Great question. So there's, in the FDA, not to get too technical again, there's different regulatory ways you can get through and get approved. This drug was approved in what was called an accelerated approval. In other words, they saw some really interesting data based on response rate, in this case from a single arm study known as SORAYA. And what they now await is the final approval, which I personally think is going to be a no-brainer. Yep. But that application, I understand, is probably in or close to in, and so we should hear something likely within the next 6 months or less. Okay. So that'll be exciting, and full approval. So the big thing is to just remind your physician to make sure you're testing for folate. We get it in a panel up front now, so we know how to plan the patient's journey.
Oh, absolutely. Yep. Now, we did promise 2 abstracts. So we've taken a little bit of time on the Mirasol abstract, but this next one is kind of exciting because, and I'll let you dig into this a little bit, but the Destiny Pan-Tumor 02 is tumor agnostic. And that is, from a clinical standpoint, is super exciting because we're not trying to fit patients into a diagnosis box and give them a drug based on their diagnosis. We're looking at the actual characteristics of their tumor and treating that. So I'll let you dig into a little bit of that.
Yeah, this was presented by Funda Merrick-Bernstrom from MD Anderson, and what I think is really exciting about it is that they did look at 7 different tumors, including pancreatic, biliary, bladder. So that was, really interesting. What I was obviously struck by was that the 3 leading responders for this antibody drug conjugate, so this new platform again, using a different antibody that went after HER2, which many of you know from breast cancer. Right. And there's new generations of that now, and then putting that with the antibody drug conjugate, is how we're seeing these outstanding response rates. But in cervical cancer, endometrial cancer, and ovarian cancer, we saw outstanding response rates ranging from 64% to 85% in women that were heavily pretreated.
Wow.
Yes.
So
and that's what that
super exciting.
And that's another point, is that this wasn't a frontline treatment. This wasn't a first treatment given. To see those kinds of numbers after patients have had multiple other lines of treatment is huge.
Yeah.
So great advancements that came out of ASCO this year, and so we're going to continue our series as we move forward. Hopefully you've learned a little bit, and of course just knowing that there are scientists and there are doctors and there's a world of oncology out there where people are working to try to help these patients that are dealing with cancer survive and have longer lives out there. So we thank you for joining us today in this Medical Minute, this special series. Like, share, and follow us, please, and subscribe. We will see you the next time for another Medical Minute soon.